on pediatric GI drugs. I'm Terry Wu, and I have no relevant financial relationships to disclose. We do have to disclose when we talk about off-label use, especially of certain drugs. So we will briefly talk about off-label use of the other vitamin D, which is Zofran, and methylnaltrexone here in this session. So our objectives are we're going to give you some up-to-date information about GI drugs, as well as talk about the safety and efficacy of these GI drugs in children. So, you know, we all are pediatric providers. We all have dealt with these common pediatric GI. I mean, really, when you think about respiratory and GI are two sort of bread and butter, right? That and well visits. So colic, we're going to talk about colic. We're going to talk a little bit about gastroenteritis, constipation, GERD, dyspepsia, and functional abdominal pain. These are what we see all the time in pediatrics, right? 50% of kids show up with regurgitation or colic or constipation in the first 12 months of life, right? So that's just the way it is. When we look specifically about colic, 10 to 20% of pediatric visits in the first 4 months of life are related to colic. And I mean, you know, it's really, the parents are exhausted. They are stressed out. They think they're doing something wrong. And it's, you know, if we could find the magic cure for colic, we'd be really wealthy, right? They would come to our doors. They would love this. So there's, you know, I've been practicing, you know, since 1993 as a pediatric nurse practitioner. And I've seen lots of things come and go. Diet is a big one. So there's been a lot of studies looking at diet. There was this great study done in Turkey. So what they looked at is and you know, diets and breastfeeding are the same around the world. I mean, the diets change, but people breastfeed all around the world. So when you say it's one thing, the problem is that could be something that's used a lot in another country, and those babies have colic or they don't have colic, or they don't eat that at all. So in Turkey, what they found is that that non-colicky infants, that the mothers of non-colicky infants consume significantly more grapes and lemons than mothers of colicky infants. And that the crying time was negatively correlated to the percentage of protein and the percentage of potatoes in the diet. So basically what they're saying is, and if bananas also caused more colicking. So, so in the Greeks, basically anywhere. So more protein, grapes and lemons, but stay away from bananas, and walnuts was another thing. So, you know, kind of weird foods, right? We often will tell moms the first thing you want to try is eliminating all milk or dairy from mom's diet to see if that helps with breastfeeding. And basically doing a low allergen diet. But while you're talking to them, say bananas might be another thing they want to consider eliminating, because there are studies that prove that. So the Cochrane reviews, the last one, they've done it many times. The last one they did was in 2016. All of us, you know, we like the little Mylicon baby drops, right? It gives them something to try. There's no evidence to support the use of methicone. There is some very low quality evidence for the use of herbal teas, which is chamomile tea, up 1 to 2 ounces a day. Low quality, maybe, that means maybe it works. Or sucrose. So those are sweeties, you know. Sweeties help for a lot of things now. What an interesting thing that you'd think, just give them a little sugar, that will help them. So there is a little bit of low quality evidence. When you think about colic, you don't want to be giving those babies sugar, Swiderog all the time. It's really not a good idea, okay? So what does seem to work is the use of probiotics, okay? Specifically L-reuteri. There have now been many, many, many studies done, and especially in Australia, they've done a lot. There's this group down in Australia that has done a lot of studies on this, and we first started seeing this around 2013, 2014, but every study that comes out, pretty much about a 50% reduction in crying with some babies, all right? They have less regurgitation. they may have more frequent stools. But if you think about those breastfed babies, right, they poop all the time anyway, so that's a kind of hard one to determine, all right? The probiotic, it's not the lactobacillus that you use in older kids, it's the L. reuteri that worked. There is a systematic review that was published in 2016 of 17 studies, and they found that the average crying time in this pooled study decreased 55.9, 56 minutes a day. Now, they didn't stop crying completely, they didn't completely cure the colic, but they cried an hour less a day, all right? So when you talk to parents, you need to say, this will work, maybe you'll have an hour less colic a day, right? The thing they did find too, if they had products containing phenyl, it worked 72 minutes a day. So that's more than an hour. So we're going to talk about that in a minute, okay? So the other thing that this was published in 2018, this was a meta-analysis by Sung. So she's down there, she does like a ton of probiotic studies. But what they found is actually the amount of crying improved over time up to 21 days. They kept seeing improvement, all right? So if you're telling parents to use probiotics, you have to tell them to stick it out. It's not a one-time thing. So the whole idea around this is that the gut is sterile, and what they're thinking is, in the last 50 years, our overall use of antibiotics has decreased the bacteria count in our gut microbiome significantly. So we're seeing more colic, and what we're doing is we're reintroducing one of those microbiomes, L. reuteri, back that seems to be associated with colic, okay? So if they're going to use it, they need to stick it out for at least 3 weeks, right? And they should see gradual improvement over that 3 weeks. This is what I worry about is parents, they try it and then they go, well, it didn't work. Well, one, your goal is 1 hour less a day of crying, and two, you got to keep using it to get out there. Now, those of us that have been practicing for a long time, we know that babies outgrow colic anyway, right? So is it that? Well, basically, they did a control group, and they found that the placebo didn't get as decreased crying as much. So you had better control. So they both got better, but the placebo group, or the control group that used the probiotic, had less crying, okay? So it does work better, all right? Now, the other thing too is there's a range, right? But once again, this is a 2018 study. If you look at the top one, which is the dotted lines, the placebo group definitely didn't get better as fast or as much as your group that used their probiotics, okay? So this is one thing we can try. There are now, if there's money to be made, there's lots of different formulations now of the L. reuteri probiotic. Gerber Soothe was the first one, but now there's all kinds of infant probiotics. Now, gripe water is the other one, and this is the, oh, my slide slid. Sorry, I've just got to fix this really fast. Uh-oh, my recorder people are going to be happy with me. There we go. Okay, I'm fixing this. Okay, so the original gripe water is something that's been used in England since 1851. My husband talks about that's the reason he likes gin and tonics, because it has this very herbally smell, right? He had it, he remembers his brother getting gripe water as a baby. And, but what we have now in the United States doesn't have any alcohol in it, okay? The original one had alcohol, and it was bicarb and dill and that sort of thing. Now what we have, the current products are ginger and fennel. Some of them have a little sodium bicarb in it, not a lot, all right? So when you go back to that previous slide that talked about the decrease in colic with fennel products is even better than with the probiotics, this is why gripe water may work well, is because there's some fennel in it, okay? Now there's lots, like I said, if there's money to be made, the original Woodward's gripe water, if they buy it in the United States, does not have alcohol. Now, a lot of us have families that are from overseas, and grandma might bring some from X, Y, or Z country. I'll use Malaysia since that's where my mother-in-law was. That might still have alcohol in it. So make sure if they're using gripe water, that's something purchased here. You can buy it at Target, you can buy it at everywhere, okay? So those are the two things you can try with colic. You can try, and you can use both. They don't hurt or cancel each other out. You can use the L. reuteri probiotics, or you can use gripe water, okay? And by the time they've tried them both for 3 weeks, everybody's going to be a little better anyway. Doesn't matter even if nothing works. Yes?
Dosing and frequency?
Dosing of the L. reuteri is once a day, and it's on the package. And the gripe water dosing is on the package for infants. Okay, I just tell them to follow the directions because they're all a little bit of different strengths, so they should all have a dosing for infants. Okay? All right. Gastroenteritis. So gastroenteritis, we all know that oral rehydration is best, right? And the best thing to do is to have a good advice nurse that talks to them over the phone, that has them try something at home. I work in urgent care. How many of you literally had them come screeching tires into the parking lot because the kid vomited one time? Oh, yeah, see? I mean, it's like, what have we done? I mean, when my kids were little, I would have been embarrassed to show up if my kid vomited one time and I went to the pediatrician, right? I mean, but because we give everybody vitamin Z, that's a problem, okay? So just remember what works best is oral rehydration. The formula is 10 mils per kilogram every time they have an episode of diarrhea. Overall, as you're rehydrating, 15 mils per kilogram per hour. Any of them work. If they are at home and all they have is Gatorade and the kid's a little older, toddler and up, I say give them some Gatorade, add a little bit of salt to it, they're fine. Infants, I still like to use the oral rehydration solution because you have a better ratio of the glucose to potassium and sodium in that, okay? We only need IV hydration for severely dehydrated kids. And the research says that it takes just as long to get the kid with their labs drawn and start an IV as it does to get them orally hydrated. So you might as well do oral hydration. The best study I ever done was a PNP, or a pediatric study. I'm pretty sure it was a nurse practitioner. But any of you in a DNP program want to do a project? What they did was they had them, when they started in the waiting room, the nurse triaged them and gave them a bit of oral rehydration solution, a syringe, and a log. And while they waited, they did the 5 cc's every 5 minutes in the waiting room. So by the time they got back to be seen, you knew whether they tolerated oral fluids or not, right? And guess what? The admissions to the hospital was lower, the use of the antiemetics was lower, and the patients were much more, the parents, I should say, were much more comfortable going home with instructions to do oral hydration because they already had seen that it works, right? The problem is we're trying to churn people through so fast that people aren't taking the time to teach people how to do proper oral rehydration. So that's what if you're in a DNP program, that's a good replication study for your group, right? To show it works, and it does work. Don't use any antimotility meds. When people say, can we use diarrhea medicine? No. Well, we say we don't want that stuff to stay in. We want that diarrhea. Helps get that virus through faster. There is very good evidence for using probiotics, but for this, you want to use the lactobacillus-containing probiotics, okay? And it does shorten the course of probiotics with both antibiotics and viral-induced diarrhea by about 24 hours. I prescribe probiotics every time I prescribe antibiotics. And it used to be, we thought maybe only while they were taking the antibiotics. I now say to do it 3 to 4 weeks afterwards. We think it takes about 3 to 4 months for the gut microbiome to recover from each dose of antibiotics we prescribe. So giving them the probiotics helps that get less antibiotic-associated diarrhea, as well as help that gut microbiome to get back to normal, okay? And there's lots of studies happening on that right now. So that, I think, is only going to get stronger. Antiemetics. So this is the thing. I was really anti-Zofran for a long time, and I'm still anti-Zofran as first-line therapy, and they've only vomited one time. I will give it if the kid comes in and we've truly trialed oral hydration, or if they're really dehydrated, I'll give it to them and then give them a Pedialyte popsicle. The problem is it works and it's cost effective, but it is not to be used for routine use for mild gastroenteritis. It's not labeled that way. It's off-label, and there's no difference in the outcomes. All you've done is you've trained parents that they have to be seen every time their kid vomits. And you know, what are we in this for, right? We have a drug that's not been tested well in kids. Yes, it's fine to be using if they're using it for chemo-associated nausea and vomiting, but really, and what I've been seeing is people sending kids home with a whole bunch of it, right? So and so the newest up-to-date, if you use up-to-date, the 2018-2019 says that you should not be using it, if they're not dehydrated, you should not be using it for simple acute gastroenteritis. You should be using oral hydration, all right? Thank goodness someone finally agreed with me, because I've been saying that for a while. All right. So it's off-label. It's only approved for chemo-related and post-op nausea in kids, all right? If you go to the ED, everybody gets Zofran. I'm not kidding. They give it for migraines. They give it for head trauma. They give it for sore throats. I mean, everybody gets Zofran in the ED. I think that that's just part of their protocol. It really, you know, that's inappropriate use, right? And there were some safety concerns because high-dose Zofran actually can cause prolonged QT, all right? And there is some studies that say they actually increases the diarrhea that they get. Now, that is not on the label. So someone goes, well, I haven't heard that. I'm like, yeah, but some studies say that. So do you want to give somebody for gastroenteritis something that's going to make them have more diarrhea and they really don't need it? I said, just give them oral rehydration, okay? I had a phone nurse, we cover the phone nurses because I work weekends a lot. The message was a 9-month-old had been seen and was for vomiting, and they've been giving the Zofran just like they said every 8 hours for 6 days, and he was still vomiting. And I'm just like, oh my goodness, who gave somebody, a 9-month-old, that many Zofran, right? Yeah, that's bad. And a 9-month-old that's vomiting for 6 days, there's something wrong, right? There's something wrong. So if you're sending them home, I will send them home with one more dose. They get one tablet more than what they get in urgent care. Because the problem is they get into this whole routine of not even trying oral rehydration first. And it's not approved, folks. Guess who's going to have to sit on the witness stand and defend themselves for not using something that's not approved? What if that kid had increased ICP or something causing that vomiting? And they've been getting Zofran every 6 hours for 6 days or something like that. I could not believe it. But somebody had prescribed it to that kid, okay, a 9-month-old. So don't do it. Just hold off. Use it very judiciously. That's the way I say it, okay? I always say you have to squeak Zofran out. Anything Z, pretty much. Squeak it out of me. It doesn't come easily. Constipation. Oh, how many of you feel like some days that's all you deal with, right? Oh my goodness. What is the deal? Well, our American diet, it's called the SAD diet. Standard American diet, SAD, right? Does not have a lot of fruits and vegetables in it, right? And a lot of fast food. So if you want to get kid constipated, you just do the standard American diet for about a week and they're going to be constipated, right? So the thing is, it's very expensive to us, right? We know about a third of kids by age 12 are going to have an episode of constipation. But when we look at Medicaid data, the cost of just 10 states, so multiply this times 5, right? $66.8 million. on constipation. All right? That's a lot of money for poop or not pooping. All right? That's not okay. We need to really work on our families feeding these kids at our well visits. We need to really start working on getting better diets in. There are guidelines. 2014 was the last time they're updated. If you go to the AAP website, this is what you're going to find. And these are the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition. They've joined together because kids are the same in the US and Europe. They both get constipated. So we have one set of guidelines, and that's what you got, okay? So the first thing we need to do is explain to parents what normal poop is, all right? What is a normal, like, you know those breastfed babies, they go from like 10 poops a day to like 1 every 3 or 4 days. So those parents come in, they're constipated. Well, when they went, how was it? Well, it was just all over, went up their back and down their legs. And I'm like, that's not constipation, that's normal breastfed stools, okay? So first we got to do that. And then we need to really, you know, kids kind of have a lot of variation in their stools until they're about 3, and then they kind of settle into like maybe once a day. Constipation is delay or difficulty with defecation that is present for greater than 2 weeks, all right? So they have to really have a problem, not just 1 day, not a couple days, 2 weeks, okay? So first thing you need to do is pay attention and make sure you are not missing something. So make sure you're not missing something like, oh my gosh, my brain just lost it. Hirschsprungs, okay? Ask them, did they have that stinky gray, black poop when they were still in the hospital? Did they have a delay in their meconium passage? Are they gaining weight well? So don't miss something that is like, you know, a thyroid problem or Hirschsprungs or something like that, okay? Are they breastfed? You know, did they ever have that time when they're having lots of poops or not? Most breastfed babies, you know, go through that period of time. If you've ever breastfed, you're always carrying poop diapers around. And then the normal pattern is all over the place. Because what they do is like, go, well, my other child didn't do it this way. You got there's like a huge range, right? You know, and the range is you know, that child is unique. So when they poop, is it soft or is it hard? Is it hard for them when it comes out? Not that they screw their face up and act like it's hard, because there's actually a term for that. They have a diagnosis for that. Basically, you know, I always say, try to lay on your back and poop. You'd probably kind of scream and strain and go, ah, you know. I mean, like infants, I mean, think about that. We all kind of get in a position to go, right? And so, one, are they getting kids, like those toddlers that are starting to potty train, are they supporting their feet? Or have they got them sort of hanging on the toilet when they're trying to go and they're afraid they're going to fall in, so they're not wanting to let go? So you got to kind of walk families through this, all right? But infants, there's a range. 5 to 28 times a week is the range, right? You're going to have one that only poops once every 5 days, and you got one that poops 5 times a day. So they're all over the place, all right? Functional constipation. So this is a kid who really meets the definition. 2 weeks, hard poops, not working, right? So what doesn't work is fiber. Fiber doesn't work after they're already constipated, okay? Preventing constipation is different, but once they're constipated, don't add a whole bunch of fiber on top of that. That's just going to cause more problems. Fluid doesn't help once they're already constipated. You got to get that going earlier. Probiotics doesn't work. Behavioral therapy, biofeedback, all these other things don't work, okay? And for functional constipation. What does work? What does work? Miralax. Polyethylene glycol, all right? Guidelines are same around the world, all right? Whether you're in the Netherlands, Australia, UK, United States, we all say everybody's using polyethylene glycol. The dosing is there for a clean out. You have to clean them out and get all that hard poop out of there so that their gut, their bowel can start to get normal sensation back. If it's been constipated for a long time, they don't even have the normal sensation of how to poop anymore. They just are plugged up and it hurts. So the dosing is you do it for 3 to 6 days also. Now, this drug works, it's an osmotic laxative. It's not like what we used to use, we used to give them Ducalox, right? That was a stimulant, and that worked pretty fast, right? But an osmotic, it's like slowly melts the big stool ball. Because I'll have parents go, we never saw any big chunks come out. What it'll do sometimes is it just, all you see is they poop, but they don't, it just kind of slowly dissolves it because it's sort of do that. So don't tell parents they're going to maybe have big chunks like we used to when we were just using a stimulant laxative, all right? The guidelines say you can use an enema. It's equally as effective. And if Miralax or polyethylene glycol is not available. Now, if you ask the kid, they will help the parent drive to the next store or the next town to find the Miralax. And the most parents will drive to the next town to buy Miralax. Or the store brand is fine. Basically, every grocery store carries it now, right? So it's pretty easy to get. The dosage there for clean out is 1 to 1.5 grams per kilogram per day. It's a lot. It's a lot. It's pretty much what you do. Has anybody had a colonoscopy where they use the Miralax for their bowel clean out? You do the whole bottle over 2 days. Okay? I thought this is great. You just mix it in some Gatorade, 2 days. You don't have to use the big old Gold Lightly stuff. But it works, okay? And it does clean them out. So, but you do it for 6 days to get them totally cleaned out. Yes?
So you start the Miralax after they've had 2 weeks of no poop, and at what age is it okay to start?
So that's where the guidelines are. They don't really talk about that. I don't use Miralax under age 1. I'll use lactulose or something, and I'm going to talk about that in just a minute, okay? So you get them cleaned out pretty much till they're clear water poop, and so it's 3 to 6 days. So I tell them to do it on a weekend, so that everybody's home, you can poop a lot. All right, and then you want to keep them on maintenance therapy, all right? And the guidelines talk about maintenance therapy based on weight. So half a capful daily up to 20 kilos, 3/4 of a capful up to 40 kilos, a capful daily, and you give it in 6 to 8 ounces. I basically tell them our goal is to have oatmeal consistency poop. Okay, oatmeal consistency. You don't want it too loose, and you don't want it too runny. So I said, if it's too runny, decrease it a little bit. If it's too loose, if it's getting too thick and it's getting hard, increase it a little bit, okay? Keep it at oatmeal consistency. The important thing is they need to be on maintenance therapy for 2 months. Now, how many of your families fall off the wagon on this one? Yeah. You get them back, oh, no, we're not doing it anymore. And, 2 or 3 months later, they're back. They're come in for what? Abdominal pain. So you got to do your whole workup for the abdominal pain to prove to them it's really constipation that caused this stomach ache. And then you're back to using the Miralax. So 2 months minimum. I work in urgent care. So what I do is I make their appointment for 1 month later to see their primary care provider so that the primary care provider knows they're being treated and that they can follow them and reinforce that they need another month's worth, and then they can think about that. The other thing is you want to decrease it gradually. For some reason, if you do it too rapidly, they get constipated again. But if you decrease it rapidly and increase their fiber in their diet at the same time, they do okay. You should not do any stopping of Miralax during toilet training. You want to make sure they're completely toilet trained, because these kids with stool holding because of toilet avoidance, they will really hold their stools. And giving them the polyethylene glycol during that time will keep them from doing stool holding as part of their toilet training. It's really important to treat them adequately and early, because kids can have prolonged problems with their bowels because we are not being aggressive early enough in treating their constipation. This is once they're already constipated. We got to talk about prevention also, okay? All right. Methyl naltrexone. Like I said, if there's money to be made, they will figure it out. So with the opioid crisis, there is the opioids work on the mu and kappa receptor, and they slow down GI motility. So what did they do? They developed a drug that works on, it's a selective antagonist of the mu receptor so that people who are on chronic opioid therapy don't get constipated. All right? I think it's interesting, but it's on a patent right now. They have studied this in kids that are getting opioids for cancer. It's well tolerated, but it's not labeled for kids because kids don't get constipation from opioids. They get constipation from their diet and behavioral issues. There's another new one. This one is for chronic idiopathic constipation in adults, and it works on the chloride channels in the bowel mucosa. It can be used for chronic idiopathic constipation in adults and opioid-induced constipation in adults. It's not to be used under age 18. They did do a 12-week randomized, this is on the label, double-blind, placebo-controlled trial of kids 6 to 17 years, and it did not work very well, okay? And so that's why it's not approved in kids. It doesn't work for chronic constipation in kids, all right? I love the name of this one, Motegrity. This one is a serotonin receptor agonist. It stimulates colonic peristalsis. It's used for chronic constipation in adults. It's also not approved for kids, okay? All right, so all those things to see, the ads on TV, we don't use them in kids, but they have been studied. GERD, let's just briefly go through GERD. We all know what GERD is, they're spitters, right? So GERD is when they actually have irritation of the GI, the upper GI tract from the chronic acid. They don't gain weight well. They are very fussy. You have the happy spitters, and you have GERD. Be sure to make a difference. There has been new joint guidelines published in 2018, okay? The GER, these are the happy spitter, right? If they're gaining weight and they are just happy, they just every time they eat, these are not in the new guidelines. They basically ignored them. They say if they're gaining weight and look good, they just left them out of the 2018 guidelines. So these are from the 2009 guidelines because that hasn't changed since my 31-year-old was a happy spitter, okay? He spit up all the time. So you can try thickened formula. You have to be very careful because if you put 1 tablespoon of rice cereal per ounce, you get to 34 calorie per ounce formula. So you see parents, they give them this, almost looks like rice cereal in a bottle. That's not what we're talking about. So a little bit. The AR formula is where it actually waits till it hits, it looks like normal formula, and it has normal caloric content. When it hits the acidity of the GI tract is when it thickens, okay? There's all these sensitive formulas. They can try that too. They can try hypoallergenic formula. Basically, spitting goes away. Most of the kids outgrow it. They just spit up. If they're going longer than 18 months and they're still spitting up, there's a problem and they should be referred. But most kids stop spitting up, okay? Not a problem, as long as they're gaining weight. And I always say, we're happy to weigh your kid every week if you want. And as long as they're gaining weight and they're happy while they spit, don't feed them so much. That's the other thing, they're overfeeding them, okay? GERD, you want to think about alarming systems. Are they not gaining weight? Is there blood in that vomitus, etc., all right? Try thickened feeds, prevent overfeeding. You want to try 2 to 4 weeks of a hydrolysate formula or amino acididates formula. If they're breastfed, they want to eliminate cow's milk from the maternal diet and refer them. And they used to say, don't give them anything. But how many of you can get somebody into Peds GI within the next 3 months? Right? It takes around us, it's about 3 months to get into Peds GI. So now what they say is while you're waiting for your referral, you can go ahead and trial 4 to 8 weeks of acid suppression, but then wean them off. So there's a whole algorithm, and the thing is that what they want is that we're not just randomly giving kids acid suppression. There's a very big concern about these medications long term. We have no long-term studies in kids, but they are, so they're saying 4 to 8 weeks, refer them, and a lot of times they don't work, but sometimes they do. So you have a very small percentage of kids that may get better. If they get better, you want to try to wean them off after 8 weeks. You shouldn't have kids on it for months and months without going to see Peds GI, all right? So, starting to restart the recording? Okay, good. All right, so I just want to finish up the pediatric GI drugs. I wanted to spend a little time on the PPIs and also about how to manage heartburn in children and adolescents. It used to be a fairly rare occurrence, but actually because we're seeing so many obese kids and kids drinking lots of caffeine, we're seeing more heartburn than in kids than we used to. So the guidelines from 2018 do address heartburn in children and adolescents. The first thing they recommend is lifestyle changes, and that includes avoiding caffeine, chocolate, and spicy foods, and also weight loss, because we think about older people when their big guts are pushing up on the diaphragm and pushing the gastric contents back up into the esophagus, but it can happen with children also. Caffeine increases pepsin and hydrochloric secretion and relaxes the lower esophageal sphincter. So that's a lot of kids are drinking sports drinks and going to Starbucks and all these things that much more so than used to be. So be sure to ask if they are getting caffeine of any form. And then, of course, encourage them to lose weight. If they continue to have symptoms after lifestyle changes, you can try a 4 to 8 week trial of acid suppression, and they do recommend the proton pump inhibitors for that. And that, once again, only 4 to 8 weeks. And what you should do is after that, you want to wean them off. You don't abruptly stop it, because what happens is they get this sudden surge of acid secretion, and then they're like hooked. They go, oh no, I don't want to have that feeling again. So you kind of wean them off to like every other day. They last 24 hours, so you can go to an every day as a matter of weaning them. If their symptoms persist beyond 8 weeks of treatment, then, or you can't wean them off, then they do also need to be referred to Peds GI, okay? So let's just talk a little bit about some of the long-term concerns about these drugs. One, you need to know that they irreversibly inhibit the proton pump that secretes gastric acid for the 24 hours that they are working. So you get about a 90% reduction in gastric acid secretion during that time. And they're recommended only for severe GERD, not like just a little heartburn. You really need to, make sure that they're treating severe GERD. In children and infants, there's really no difference when they've done placebo-controlled trials between using a proton pump inhibitor and not in GERD symptoms. And so that is why, when we're looking at sort of early this morning, we talked about how the FDA has got very specific guidelines for outcome criteria for studying the proton pump inhibitors. It's because the disease itself is kind of fuzzy and hard to diagnose. And so there is an increased risk of C. difficile because of the significant reduction in acid production. That acid production actually kills some bacteria as things go through the gut, so you do increase the risk of C. diff. In adults, there's other long-term issues that we're going to talk about. So in the guidelines from 2008, Rosen et al. Said, it's uncertain whether the use of PPIs reduces crying or distress, visible vomiting, regurgitation, or signs and symptoms of GERD based on a tool that they were using compared to placebo. So, even though the guidelines say a trial, even they say they may or may not work, okay? And there's really no good outcome criteria to determine how well these work. The concern is the long-term effects of putting children on these, especially over a long period of time. You'll notice the guidelines say 8 weeks and then refer. What we're finding in adults is vitamin B12 deficiency, There were some possible gastric tumors, decreased calcium absorption. So you think about kids that are growing, they need to be able to absorb those nutrients, and any nutrient that needs acid for absorption will be affected by putting them on a PPI, which has such significant effects on acid production. In the elderly especially, they have immobile elderly people, they have more hip and spine fractures, and they think it's just because of absorption issues. What is the most concerning, though, is these more recent studies that have come out around the PPIs and chronic kidney disease. The first one was published in 2016, and the story behind this is quite interesting. It was a woman who was totally fine, and she was put on a PPI, and she suddenly, on her labs, indicated decreased renal function. And she told the doctor, do you think it's that medicine? They go, oh, no, I'm sure not. That's a stomach medicine. So what they then they sort of got curious, and they did this large study of 10,000 adults, and they found that patients with proton pump inhibitor use had a higher risk of chronic kidney disease. And if they used it twice a day, they had even increased risk. And it was not the same with the H2 receptor antagonists, which are like your ranitidine and your cimetidine and those other antacid drugs. And so that was really interesting. And so the VA, who is a closed system, meaning they can follow the patients that have the diagnosis and have the prescription written and the long-term effects, so they can really, it's a nice closed system. They studied over 144,000 patients on acid suppression treatment. So they looked at all the patients on acids. So we're looking at both the patients on PPIs as well as the patients that were on the H2 receptor antagonists. And what they found is that there was no risk of kidney injury when patients were on H2 receptor agonists, but they did see it on patients on proton pump inhibitors. So this brings up a very big concern with, one, what are adults we're going to do long term, because these are two very large studies that have found these kidney problems. And also, it makes me reiterate why we don't want to just put kids on a medication that has not been studied short term or really long term in kids about safety concerns. Yes, it's short for the first few weeks, but we don't know what that looks like 5 years, 10 years, or even 5 or 6 months later when you have a growing child on a medication that we now know does have significant long-term effects in adults. This was not a surprise. About 10 years after these came on the market, there was a couple authors came out and said, you know, we are playing with fire. We've got all these people taking these medications. We have no long-term data. These only been on the market a short period of time. And now that they've been on longer, we're starting to see some of the long-term true effects of these medications. And when you can go down to the grocery store or the drugstore and buy whatever you want and take it as much as you want without any guidelines, that is a concern. We are in charge of children, so we need to be judicious in our prescribing. Because of this, the Centers for Medicare and Medicaid have come out with some guidelines and suggestions about overprescribing for children with reflux. Basically, this is talking about multiple studies indicate that they're overprescribed. Even doing pH studies doesn't really give you an accurate diagnosis in children. There's no improvement in symptoms. Most of the time, they're not prescribed according to guidelines. And so the Centers for Medicare and Medicaid, basically CMS, who takes care of all of our Medicaid children, have put out this document about, look, you know, pay attention. Don't overprescribe these medications. Because guess who's going to have to pay for the long-term sequelae of overprescribing these medications? Not only are they paying for them now because they're being prescribed inappropriately and they're expensive, but also if there's long-term sequelae, they're going to have to pick up the bill. So just pay attention to that. So to wrap up the GI drugs, I just want to give you the clinical resources. the North American Society for Pediatric Gastroenterology and Hepatology and Nutrition is, the website is there, but they give you the practice guidelines for constipation, GERD, the use of probiotics, chronic abdominal pain, H. pylori.